Welcome back to the deep dive. Today we are taking on one of those conflicts that I think is just unavoidable in clinical life.
It really is that impossible juggling act.
Exactly. The clash between, time-critical clinical care and all of those crucial non-clinical duties you still have to do.
It feels like a zero-sum game sometimes, doesn't it? The clock is just always against you. We're talking about, say, a deteriorating patient on one hand, and then your commitment to teaching or QI on the other.
Yeah, and we've all been in that exact spot. So let's set a scene based on the material we've got. Imagine this. You've prepped all week for a mandatory teaching session. It starts at 2 o'clock.
Right.
But at 1:45, it all goes sideways. Your bleep just goes crazy.
Of course.
2 patients on your ward trigger high NGWS2 alerts, so they're actively getting worse. And a third patient needs complex, high-risk prescribing sorted right now before the pharmacy cutoff.
And there's the dilemma right there. It's immediate. Do you run to the meeting so you don't let people down, or do you stay on the ward and manage this surge?
And crucially, if you do decide to go, how on earth do you do that without just abandoning your duty to patient safety?
Exactly.
So that is our mission for this deep dive. We're going to distill those core GMC-aligned principles and give you that essential step-by-step framework to manage this whole conflict professionally.
We need the tools, don't we?
We do. Tools that make sure patient safety always comes first, but also, protect that vital professional development time we all need.
And if there is one central truth, just one thing to internalize today.
The one-sentence takeaway.
That's it. It is this. Always put patient safety first. If you absolutely have to step away from the bedside, you must, and this is non-negotiable, you must first arrange competent cover, set very clear thresholds for when to call you back, inform everyone who needs to know, and document the whole plan.
Before you even move an inch.
Before you move an inch.
Wow. And that one sentence really is the difference between professional delegation and, well, just chaotic abandonment, isn't it?
It is. This isn't just about managing your diary. It's about risk management, continuity of care, and, fulfilling those core GMC duties. Getting this wrong isn't just about a bad score on a test.
It has real-world consequences.
Big ones. That's why this topic is so high yield. It tests your professional integrity right when you're under the most pressure. It's asking, do you understand that teaching and QI are vital, but they never, ever supersede immediate patient risk?
So let's anchor ourselves in those regulations then. What does balancing workload actually mean in this context? How does the GMC define the boundaries here?
Okay, so fundamentally, it means meeting all of your clinical duties, and that includes the unexpected stuff, the acute demands, while still keeping your commitments to teaching, supervision, admin, all of that.
But there's a big but.
A huge but. The critical thing is you have to do it without compromising safety and also without being unfair to your colleagues, but just dumping tasks on them.
Right. And the GMC principles themselves, they're pretty clear on this, aren't they?
They are. They really boil down to 3 simple, non-negotiable points. The first one is prioritize patient safety.
Okay.
And that means knowing your limits. If you're too busy to safely review a patient, you have to escalate that problem. You can't just try and squeeze it in when it's not safe.
And the second principle, that touches on handover, which is, that's central to this whole scenario.
Absolutely. The second one is that delegation and referral require clarity and oversight. You can't just wander off and say, can someone deal with that high new WS2?
Wait.
You have to make sure the person taking over has the right grade, the right skills, and that they understand the context. And you still have oversight until that task is properly handed over.
So you're still responsible in a way.
You are. Until that handover is complete, you are.
Okay, and the third principle, this is the one I think people forget in the rush.
They always do. And it's so important. It's keep clear, accurate, and timely records. If you arrange cover, if you set a threshold, if you postpone a meeting, you have to write it down.
You have to document it.
You have to. Because if there's an issue later, that documentation is the proof of your professional decision-making. The SJT rewards it because the GMC demands it.
And that brings us right to the exam mindset, doesn't it? It's simple. Patient safety outranks meetings. Full stop.
That's it. The exam will heavily reward choices where you secure competent cover, you communicate clearly, ideally using a tool like SBAR, and you document the entire plan.
And on the flip side, it will punish you for.
For anything else, really. For prioritizing that QI meeting over an unstable patient, for leaving the ward without sorting proper cover, or for doing some sort of, silent, undocumented swap with a colleague. Safety first is the only way to score well here.
Okay, that's crystal clear. So let's move from the principles to the practical steps. It's 1:45, the bleep is going off. We need a clear, stepwise framework. What is the absolute first thing you do?
The very first step, before you even allow yourself to think about the teaching session, is to scan acuity and risk. You have to rapidly assess the situation on the ground and decide if it is genuinely safe to even consider stepping away.
And you're looking for red flags.
Exactly. You're hunting for red flags that mean you absolutely have to stay.
And what would those be? Like, give us some real-world examples.
Okay, so immediate red flags are those rising new WS2 alerts we talked about, or any patient who is acutely short of breath or hypotensive.
Right.
Also, high-risk tasks that are still pending, things like prescribing complex drugs, getting blood products sorted, or taking consent for an emergency procedure, or even just the simple fact that there's no senior cover available right now.
So if you see any of those, the decision is made for you.
The decision is made. You stay, you escalate the clinical problem, and you reschedule the non-clinical work. That is always your highest scoring option in that situation.
Okay, but let's say for the sake of the framework, you've scanned the situation and you think, you know what, I could probably defer this if I get proper cover. What's next?
Then you must immediately arrange competent cover. And I can't stress that word enough, competent. It's key. It means the colleague taking over has the right grade and skills for the tasks.
So you can't just ask anyone.
No. If you're an SHO and you need a patient with sepsis reviewed, your cover needs to be able to handle that, and you have to brief them properly.
And that briefing has to be structured.
It has to be. SBAR is perfect for this. Situation, background, assessment, recommendation. You tell them exactly what's wrong, what's been done, and what you think needs to happen next.
And here's the trap detector moment, isn't it?
It is. Here's the trap. You must never, ever ask a medical student to hold the bleep or take clinical responsibility. They're learners, not cover. It's unsafe delegation, and it will score you 0 points, maybe less than 0.
Right. So cover is secured and briefed. Step 3 is communication. Who do we need to tell?
You need to inform stakeholders early. That means, number 1, the nurse in charge on the ward. They're your eyes and ears.
Your key ally.
Your key ally for safety. Then the education lead who organized the teaching. And crucially, the hospital switchboard, especially if you're the one holding the on-call bleep. Everyone has to know who is responsible for what.
Okay, and the 4th step is about setting clear boundaries for the person covering you.
That's right. You have to set thresholds and regroup times. You can't just leave it open-ended. You need to say, please escalate to me or the registrar if the patient's SATs drop below 92% or if the new WS2 hits 5.
You give them specific triggers.
Specific objective triggers, and you must give a clear return time. I will be back on the ward at 3:05 to check in. That stops things getting lost.
And the final step, step 5.
You have to document the plan and outcomes, note down who's taking responsibility for how long, what the escalation thresholds are, and how to contact you. It just closes the loop professionally.
Okay, so that's 5 critical steps. Scan, arrange, inform, set thresholds, and document. That is a lot to remember when a patient is crashing.
Yeah.
Is there a memory hook to tie this all together?
There is, yeah. We use a simple one, the BALIN mnemonic.
Goldman. Okay, break that down for us.
So B is for bedside first, scan the acuity and risk. A is for arrange cover, make sure they're competent and fully briefed. L is for let stakeholders know. That's your NIC, the leads, the switchboard. A is for agree thresholds, set those escalation points, and a regroup time. And finally, N is for note the plan, document everything.
BALIN N. That is a really practical tool for when you're in a pinch. Now, that framework gives us the right path, but the exam, and I guess real life too, is full of wrong paths.
Oh, absolutely.
So I imagine the worst mistakes aren't just forgetting a step, but actively choosing one of these bad options.
You're spot on. And this is where it gets really interesting, looking at the common traps. The exam uses very specific, low-scoring options that are designed to tempt you away from safety.
Okay, let's hear them. What's the ultimate trap? The worst possible choice.
Trap number 1, go to the meeting and turn your phone off. This is almost always the absolute lowest scoring option.
And why? I mean, it seems obvious, but...
Because it's total abandonment of your professional responsibility. There's no cover, no escalation path. It shows 0 situational awareness, and frankly, in the real world, it could lead directly to avoidable patient harm.
Okay, what about the traps around delegation?
That brings us to trap 2. Ask a medical student to take the bleep. We've mentioned it, but it's a classic trap because it can feel tempting when you're desperate.
A quick fix.
A quick but disastrous fix. It is explicitly unsafe and incompetent. Students just don't have the legal standing or the experience. If anything goes wrong, the blame falls squarely on you, the doctor who delegated.
And then there's the more passive failure, the quiet exit.
Yep, trap 3. Leave without telling anyone. This is a failure because it means zero handover. No one knows who is covering your patients. The nurse in charge doesn't know who to call. It leads to delays, gaps in care. It's just a mess.
And what about trap 4? The vague promise.
Yes. Promise to catch up later and just quickly do the urgent prescribing. Now, dealing with the prescribing is good, but the promise to catch up later part is the bit that scores badly.
Why is that?
Because there's no specific plan. No thresholds for the other problems, like those new WS2 alerts. You're just hoping for the best, and you risk those other urgent tasks being completely forgotten because, later often never comes on a busy ward.
So the logic is just always fixed. Safety, with an explicit documented plan, will always beat just going to a meeting.
Precisely. In any scenario pattern, the options that involve clear cover and rescheduling will always outscore prioritizing the meeting. An option with a clear SBAR and threshold will always beat a vague promise. It's a clear hierarchy.
So let's talk about the language for a second. What does good, high-scoring communication actually sound like in this situation?
Okay, so if you decide you have to postpone, you need to be firm and professional. Something like, given the current clinical acuity, I'll need to postpone the teaching. I'm informing the education lead right now, and I'll stay on the ward. I'll make sure to share the slides and reschedule a new date by the end of today.
So you're taking ownership, providing a solution.
Exactly. And for the cover plan, you're communicating to the team on the ward.
It needs to hit all those BALIN points.
It does, for example. Right, cover plan. Dr. Alex, the SHO, is holding the bleep from 2 until 3. Please escalate to me or the registrar if new WS2 hits 5 or more, or if the patient's pain isn't controlled. I will be physically back on the ward at 3:05 to reassess.
That is incredibly clear. No room for ambiguity there.
Yeah.
Okay, quick FAQ. This is a crucial one. What if this happens all the time? I follow the steps, I do everything right, but I'm constantly being pulled from my protected time.
Now this is a great question. It tests your ability to think beyond the immediate crisis. So managing the crisis this time is about using BALIN. But if it's a repeated issue, the highest scoring action actually shifts.
It becomes a systems problem.
It becomes a systems problem, not just your problem. So the correct action is to address that system failure.
And how do you do that professionally?
Well, you still need to plan for cover in the short term. But critically, you need to start logging these repeated cancellations. You need data on the impact it's having. Then you take that log, that evidence, to your supervisor or the rota coordinator, and you propose a quality improvement project. You might suggest better ring fencing of time or a different rota for acute cover. You move from being a firefighter to a system improver.
That's such a key distinction. Logging the problem to drive a QI change? That feels like a really high-level professional behavior.
It's the ultimate high-scoring behavior, I think. It shows leadership, and it shows you understand that these workload issues are often systemic, not just individual failings.
Fantastic. Okay, so let's boil all of this down. What are the 3 absolute core key takeaways that you need to act on?
Number 1, safety first. Meetings, QI, all of that is secondary when you're facing acute clinical deterioration.
Number 2.
Competent cover, briefed with SBAR with specific escalation thresholds, must be secured before you even think about leaving the bedside.
And the final crucial takeaway.
Third, inform all your key stakeholders, that's the nurse in charge, the relevant leads, and the switchboard, and then document the entire plan. Who owns what, the timings, and the agreed regroup time.
And just to make sure everyone's on the same page, let's quickly run through a glossary of those key terms.
Good idea. So SJT is the situational judgment test, the part of the MSRA we're focused on. SBAR is your communication tool. Situation, background, assessment, recommendation.
Right.
NUWS2 is the National Early Warning Score, that tool used across the NHS to track patient deterioration. And stakeholders are just all the people who need to be notified of your plan, the NIC, the leads, and the switchboard.
This has been so helpful. It really shows that balancing this workload isn't a guess. It's a defined professional process. You can attend your duties, but only when it is genuinely safe. with all those pieces, the cover, the communication, the documentation, firmly in place.
It's not about hoping for the best, it's about professional planning.
And here's the final thought we want to leave you with. This balance isn't just about managing the single crisis when it hits. It's actually about advanced planning and, as we just discussed, data collection. So ask yourself, how often are you actually logging the impact of these clinical surges on your non-clinical time? Are you gathering the data you need to advocate for better protection of that time to make the whole system safer for everyone?
Because proactive planning today is what secures that essential professional time for tomorrow.
Absolutely. Thank you for joining us for this crucial deep dive. Remember, you can find comprehensive notes for this, including all the frameworks and model phrases, over at passimsurvivor.com. We hope this has given you the confidence and clarity you need for that inevitable workload clash. Until next time.